All right. Coming back, we're going to jump into acid-base balance. Again, this can be very confusing. I don't expect you to understand it all in a night. Nothing that I teach, I understand you I expect you to understand that night. You, there's a reason we spread clinicals and field rotations out through the program instead of having you guys just doing the last semester, and it's so you can see some of this stuff in real time. Um, don't You're going to feel lost at points. It's okay, because when we start to do lab and get incorporated with things, it'll make a little bit more sense. So our body relies on something called the acid-base balance. And when we say acid-base balance, the big thing that we're referring to is our level of acidity. And we look at that through our pH scale. If we were to draw labs on every single person, I'm guessing most of the people would fall in between the numbers of 7.35 to 7.45. That is the normal range. Anything outside of that, we'll talk about here shortly. But our acid-base balance can be disrupted by our respiratory system, by our renal system, and due to trauma, because carbon dioxide plays a big role in acid base. The more carbon dioxide we have, the lower our pH is going to be. It's always going to be opposite. So if I have high carbon dioxide levels, I'm going to have a low pH. Where if I have a low carbon dioxide level, I might have a higher pH. It's always going to be the exact opposite. And again, I'll play a video here shortly. So our body tries to maintain the homeostasis and the normalcy of our acid-base derangement through a couple different mechanisms. One of them being our respiratory system, just like I talked about the diabetic patient that breathes really deep in and out. That's because they're trying to blow off excess acid. That excess sugar has turned into excess acid, aka ketones, and they're trying to blow it off. That's the body's natural reaction. What else will happen is when our body sees we have a buildup, our renal system will kick in. It will basically open the floodgates and make us pee a whole lot because it's trying to get rid of excess, right? Our body tries to breathe off excess and eliminate it through urination. Now, what can be kind of tricky is we have what's called metabolic acidosis and metabolic alkalosis. And we also have respiratory acidosis and respiratory alkalosis. Now, I'm going to draw something on the screen here. I'm going to play the video after I draw this for you guys. We're just going to pay attention to our pH scale. And I'm going to draw that up here. If I was to draw a nice straightish line, and I labeled this 0 to 10. This is going to be 7.35. We'll just say this is 7.45. So anything in between these parameters is considered normal. 0 is considered an acid. 10 is considered a base or alkali. So the lower we go on the pH scale, the more acidic we become. The higher we go on the pH scale, the more alkalotic we become. Now, there's different reasons that our pH can be messed up. It could be a respiratory system problem, such as not breathing enough or breathing too fast, or it could be a metabolic problem, such as an infection. Those are the only two categories that we focus on, is respiratory and metabolic. Now, can a metabolic problem lead to a respiratory problem? Absolutely. But the only way that we can truly tell is through labs. Now, I go on a patient that's in severe respiratory distress. Let's just say I was able to draw an ABG on them, a lab, and look at their arterial blood gas, and it came back 7.2. I know that they're having a respiratory problem and their pH is affected. I'm probably going to call that, and they're at 7.2, I'm probably going to call that respiratory acidosis. An easy way that I remember this is D50. We all know what D50 is. Sugar in an ampule. We give to diabetics to bring up the blood sugar, right? D50 is very necrotic on our blood vessels. And when we get into IVs and meds and things like that, I'll explain it further, but it can tear up your blood vessels. So if I blow a vein, but I give D50, I need to notify the hospital pretty quickly because it can start to essentially chew through tissue because how necrotic it is. D50 on the pH scale is like a 3.2. So it's very acidic. Remember, the lower, the more acidic we are, the higher, the more alkalotic we are. Now, normal CO levels for a patient is between 35 and 45. If I'm looking at end title, the higher I go, the lower I'm going on the pH scale. The lower I go on CO2, the higher I'm going on the pH scale. It's always going to be opposite. Now, say that end title, the CO2 number is 38, so within normal parameters, but my pH is messed up somehow, that tells me it's a metabolic problem because my CO2 isn't skewed. So it's not a respiratory issue. And again, I'm going to play this video for you guys real quick.
Hey everyone, welcome to the Acid Base Balance Lecture brought to you by emtprep.com. We're going to do our best to simplify this information for you today. In teaching EMT and primarily paramedic students, I've found that this seems to be the most common topic that just really isn't taught well and really seems to be something that confuses students. So today our goal is to give you a good foundational knowledge, and we're not going to harp on too many details. It's just going to be kind of glossing over the main information that you should know regarding this topic. So what is pH? Well, that's a great question. The pH of blood or any other fluid is a measure of its hydrogen ion concentration. A pH of 7 is considered to be neutral when we're talking about fluids in general. However, when we're talking about humans, blood pH is supposed to be between 7.35 and 7.45. That's what we would call a normal pH. So if our pH is too high or too low, we have some issues. If it's below 7.35, we consider that to be called acidotic. If the blood pH is higher than 7.45, we consider that to be alkalotic. So let's take a look at that in graph format. So this is the pH scale. You can see that it goes from 0 at the bottom to 14 at the top, with 7 being in the middle and considered neutral. Below 7, you're getting into that acidotic environment, and above 7, you're getting into that alkalotic environment. Why is pH important? Well, our bodies are constantly working to maintain something called homeostasis. Homeostasis is just a funky word that means normal, a normal state. And sometimes our bodies have to work extra hard to maintain that normal state, like when we're sick or we're injured. And sometimes they don't have to work as hard to maintain that normal state, like when we're feeling healthy, eating well, sleeping well. Those things make our bodies work less hard to maintain that normal state. Again, something to keep in mind that we already a little bit touched on. While a pH of 7 is considered to be neutral, that is not normal for humans. A normal human pH is a perfect normal, I should say, is 7.4. A zero point 0.5 shift up or down from 7.4 is not conducive to life. So how do our bodies manage all this stuff? Well, there's three primary ways to balance acids and bases in the human body. The first is the carbonic acid bicarbonate buffer system, And that sounds a lot worse than it is. This is our body's easiest way to balance acids and bases. However, it's also the easiest system to overwhelm. If my memory serves me correctly, the carbonic acid to bicarbonate ion ratio is like 20 to 1. And so when we're trying to balance something that is so offset with a ratio like that, you can imagine that that system is easy to overwhelm when we tax it too much. The second way that we balance acids and bases is through our lungs. Way easier to say and remember than number one. Our lungs adjust pH by blowing off or holding on to CO2. We'll go over that more in a second. The third way is through our kidneys. Our kidneys are awesome organs that do a lot of things for us, and they can balance acids and bases by reabsorbing, creating, or excreting bicarbonate and hydrogen ions. Food for thought here. Our bodies take in oxygen from the atmosphere. Usually 19.5 to 21.5% oxygen is floating around in the atmosphere. When we breathe that in, we create CO2 in our lungs. CO2 is an acid. Remember that. CO2 is an acid. When we don't breathe out enough CO2, we retain that acid. And in turn, that makes our bodies acidic. On our end tidal CO2 readings, we can see this. Remember, a normal end tidal CO2 reading is between 35 and 45. If your end tidal is greater than 45, your patient is experiencing respiratory acidosis. If your patient's end tidal CO2 is less than 35, they're experiencing respiratory alkalosis because they're breathing off too much CO2. So, good question here. Can we control end tidal CO2 readings? The answer is yes, to a degree. This lecture touches on the respiratory component, not a whole lot on the metabolic component. So, with that in mind, here's a couple quick ways to remember how to regulate your patient's end tidal readings. If the patient's end tidal reading is low, go slow. You do this by decreasing your ventilation rate and depth. If their breathing is low, go slow. If the patient's end tidal CO2 reading is high, you fly. You do this by increasing your ventilation rate and depth. So if their end tidal reading is high, you fly with your ventilations. So again, please keep in mind, in EMS, we don't get the full picture of a patient's overall acid-base balance, and that's because we don't do arterial blood gases in the field. I hope this has kind of brought just a good information overview to you on acid-base balance. If you have any questions, please check us out, emtprep.com, and we'd love to hear you if you have any comments, questions, or concerns. You can email us anytime, info@emt.
Like I said, he goes a little bit further into it than I can, just because there's some stuff that I wouldn't bring up or I'd feel like I'd forget, that it's pretty important for you to know. So some of the key things that we need to know is that CO2, carbon dioxide, is an acid. In excess, it turns our body acidic. That's why we see pH levels start to drop. We become more acidic. The less CO2 we have, the less acidic we are, the more alkalotic we are. Now, if we have a normal CO2 reading, but our pH is still messed up, again, that could be a metabolic problem and not a respiratory one. But generally, if our end tidal is messed up, it's most likely a respiratory problem. Good thing is, I think from here on out through the PowerPoint is all stuff you guys should know. I feel like I hit you with the hard stuff early. I apologize. Um, Adequate breathing in whatever population, whatever demographic it is. Adult ranges 12 to 20. Children are going to be obviously a little bit higher. They don't have the lung capacity that we do as adults, so they don't have that tidal volume. They don't have that amount of reserve. Infants are going to be even faster yet, just because, again, the smaller the body, the more breaths they have to take to equal the amount of air that they truly need. If you look at like BVMs, an adult BVM is massive, an infant BVM, pretty small. One of the things that we'll most commonly see in breathers in our respiratory patients is that tripod position. The reason that people sit in the tripod position, which is kind of, sitting, leaning forward essentially, is because it takes pressure off their lungs. When somebody is laying down, the weight of their chest actually pushes against their lungs and it's hard for them to breathe. That's why you'll see some patients, especially if they're like morbidly obese, when they sleep at night, they have to have a bunch of pillows underneath them. It's because they can't lay flat. They just have a really hard time breathing when that happens. That's why you will naturally see people in the tripod position because as they lean forward, the lungs swing forward in the thoracic cavity. When that happens, the lungs are able to inflate a whole lot easier. Again, I feel like I kind of covered this. Some reasons for inadequate breaths, infections, not just a normal infection, more sepsis at this point, trauma, and it could be due to spinal cord trauma is going to be the most common one that we're going to see. It could be chest wall trauma as well, though, either penetrating or non-penetrating. Oxygen poor environments, such as high altitude, or think of like a chemical manufacturing facility where there's a lot of different chemicals in the air, maybe not a lot of oxygen. Those are the events that where we could see people essentially, starting to become cyanotic. Think of a CO alarm at somebody's house. Their CO detector is going off. That's always a concern because it's an odorless, tasteless gas, and they won't know. They'll start to get really tired because they're becoming cyanotic and hypoxic at the same time. Upper and lower airway obstructions. The tongue is the most common airway obstruction, believe it or not, in adults. Our tongue is massive. Kids, most common airway obstruction is going to be them putting something in their mouth, more of a foreign body airway obstruction. Respiratory muscle impairment. This could, again, be for a number of reasons. A lot of times it's due to a health condition, a prior health condition. And then central nervous system, your CNS system impairment. This can be due to medications, it can be due to alcohol, it can be due to drugs. So, how do we manage the airway? First step, right? Open the airway. Clear it if need be. This could be suctioning, this could be rolling the patient on their side if they start to vomit. Assessing the respiratory status. How is the patient breathing? Are they breathing adequately? Do you see equal chest rise and fall? What are their lung sounds like? What intervention is needed at that point? Again, I'm the last person to jump right to innovation because it takes a lot of time, it takes a lot of preparation, and it takes a couple hands to drop drugs and to get my innovation equipment ready or whatever it might be, as opposed to where I might be able to just bag this patient to the hospital with an OPA or a King or whatever it might be, and I could probably manage them just fine in that route. Because say I go to RSI somebody and I go to take their airway from them using medications and I fail, the medications don't just wear off. I now have to figure out a way to take over to breathe for this patient. There is no plan B if I mess that up. Things we're evaluating. Look, observation. We're looking for chest rise. Are ventilations working? Palpating. Put your hand on the chest. See if you feel the chest rise. Put it on both sides. Do you feel unequal movement? Listening for breath sounds, listening for breath sounds, listening for breath sounds. I cannot say that enough. Listen to your breath sounds. A great place to start to listen to breath sounds is in the armpit. It's very thin tissue right there. If you're going to listen to like the lower lobes of somebody's lungs, generally you listen in the front. If you want to listen to the upper lobes, you listen towards their back, up behind their shoulder blades. Some of the things that we could potentially see with somebody that is having trouble breathing or experiencing inadequate breathing, positioning, so that tripod position. Orthopnea, that is the inability to sleep at night. It goes back to what I talked about. They can't sleep at night because the weight of their chest is pushing against their lungs. Chest rise and fall, do we even see it? Skin parameters, pale, cool, dry, pink, flared nostrils. You'll see that more in kids than anything when they're having trouble breathing as their nostrils start to flare out. Pursed lip breathing, we'll see a lot more with like our COPD patients, where they'll take a big deep breath, but they have to purse their lips when they're exhaling. It's because they need that back pressure. Most commonly, you're going to see that in emphysema patients. Pursed lip is huge in emphysema patients. Intercostal retractions. So in between our ribs, we have what's called our intercostal muscles. If somebody, and you'll see this again a lot of times in younger children, if they're really struggling to breathe, you'll see the skin retract in between the ribs, and you'll literally be able to see their rib cage because they're struggling that bad, which is also accessory muscles. Asymmetric chest wall movement. This could be due to a collapsed lung. It could be due to a flail segment, such as broken ribs, that one side of the chest is rising, but the other side isn't. Quick breaths, long exhalation. That was something we always did when I played sports. You breathed in pretty quickly, but you breathed out really slowly. And then obvious signs of labored breathing. The things that we assess just right off the bat without having to, okay, I'm going to see what position the patient's in. I'm going to see what their chest rise looks like. This is common stuff that we're doing when we're walking up to the patient, and then we can assess pretty quickly. And remember, our assessment of the patient begins when the call comes out. It doesn't begin when we get there. That bullshit of what does my patient look like or anything like that. No, start building your scenarios in your head of what could be going on with your patient before you get there. Sometimes you're planning for the worst case scenario, but you're hoping for the best. Um, Inadequate ventilations per their age, maybe. So that's another indication why we would take over breathing for somebody. If somebody's breathing extremely slow or extremely fast out of the ordinary, I'm probably going to assist ventilations at that point. Irregular rhythms of breathing could be due to trauma, could be due to a brainstem injury, could be due to diabetics, Kussmaul respirations. Um, Absent noisy sounds, crackles, wheezes, absent lung sounds entirely. The most terrifying noise that I can hear when I listen to lung sounds isn't wheezing, isn't crackles. It's when I can't hear anything. And a lot of times that could be due to inflammation. It could be due to fluid buildup, that I'm not hearing air movement. Belly breathing, again, really common in kids when they're really having trouble breathing. Increased effort, shallow breathing, cyanotic looking patients, pale, clammy, almost bluish lips. Their fingers are a really good telltale sign as well. They're nail beds. Retractions, staccato speech. So as their brain starts to become, hypoxic, and as their body essentially isn't able to get as much oxygen as it needs, you're going to get what's called staccato speech, which is speaking in 1 to 2 word sentences. I wouldn't say I'm a big one for feeling for air movement. I truly don't know if I've ever actually felt for air movement or palpated somebody's chest to see if there was air moving. It was more of an observation. And I mean, looking pretty clearly to see if I could see the patient breathing. Paradoxical moment. So movement, what they're referring to there is do we have asymmetrical movement of the chest? Um, Pulsus paradoxus, you'll see most commonly in children and maybe geriatric patients, is that their blood pressure can change based on their respiratory status. Our extremes of age, our very young children, our very old populations can't compensate like we do as middle-aged adults. They don't have the ability, or they lose the ability, such as our elderly patients. So some of their other body mechanisms have to try to compensate for that. Kind of, doing your assessment on a breather can be difficult, especially if they're really having a harder time breathing. I limit my questions to usually yes or no, or something that they can answer pretty quickly without having to give me a whole detailed history. Because if they're having trouble breathing, why am I going to ask them to, recite me a whole paragraph? It doesn't make a whole lot of sense. But some things that I want to know, especially maybe the patient has a history of respiratory problems. What happened tonight that made you call 911 versus what's been happening for the last 6 years? That's an important question to ask, because that's going to tell you what changed and what scared them, especially if they live with respiratory problems, COPD, whatever it might be, for a period of time. They're used to dealing with it. If something changed so drastically that it scares them, should make you a little bit nervous as well. Another thing that I'll ask if it's a severe respiratory patient is, have they ever been put on a breathing tube before? Have they ever been intubated? If they say yes, my index of suspicion rises even further. This patient has some severe respiratory problems. Medications and overall compliance to meds. So, what meds are they on? And are they taking them as they should? That's pretty easy to tell, especially in our elderly populations that might have, Monday through Saturday pill organizers. It's now Wednesday and Monday and Tuesday are still there. That's a pretty good red flag, if you ask me. That's one of the things that I do all the time. Check the meds. Get in the habit of looking at pill bottles, figuring out what the med is. I don't know what all medications are, but my phone does. I can Google anything and figure out what it is. Because a lot of times patients won't tell you the truth, and they don't think they're lying to you, but they think their medication has fixed their medical problem. You have somebody that takes blood pressure medication, but they say they don't have high blood pressure. But when you question them about it, they say, well, yeah, the medication fixed the high blood pressure. Just simple stuff like that they don't put two and two together what you're asking. So looking at medications is really important. And then risk factors. We saw this big time with COVID. People that had depressed immune systems, our extremes of age again, are very young, are severely old, were who we were most worried about because they don't have the immune systems that we as middle-aged adults do. Hereditary factors also come into play there as well. Um, yeah, I wouldn't say sneezing is a huge respiratory thing for me. Maybe it could indicate some sort of allergen. Coughing, it depends on the cough. Is it a dry cough? Is it a wet cough? Is there any blood that's coming up with them coughing? Gagging, okay, that could indicate an airway obstruction or a partial obstruction. Sighing, so big, deep, long breaths, hiccups. Um, I honestly couldn't say I've walked up to somebody that was hiccuping and told them they're having a respiratory problem. I can't say that's ever happened. Some of the different abnormal breathing patterns that we can see, these are pretty important. So if you need to take a picture of them or whatever it might be, because even a year from now, these will come up on your national registry. So Shine Stokes is essentially, increased rate of respirations as well as an increased depth that has periods of apnea in between. So where the patient just stops breathing. Too small respirations, again, seen in patients that potentially have diabetic ketoacidosis, DKA, or high levels of blood glucose. That's the big, deep, long sigh breathing. Be it or ataxic respirations, usually due to some form of head trauma. I get that and Shine Stokes confused pretty easily because the rate and depth change and they have periods of apnea. The only difference is ataxic breathing or Beats respirations have irregular breathing pattern. Apneustic respirations, so prolonged gasping followed by short exhalations. A lot of what you're going to see is that abnormal respiratory patterns a lot of times are caused by some sort of brain injury. And then agonal breathing. That's basically the body's last chance at trying to bring in oxygen or breathe or whatever. And a lot of times you'll see that even patients that are trending cardiac arrest, as their body will start to agonally gasp. Agonal respirations are not respirations, in my opinion. Those patients need bagged. Different places, again, we can listen for lung sounds, not just in one spot. You can listen up high, you can listen up low, you can listen on the sides. My favorite place is honestly where the fifth intercostal space. Let me see if I can draw this one out. Right here, right up under the armpits. That will give you the clearest sound you can hear. Because again, the tissue is really thin. There's not any muscle right there. You will get a good breath sound. Breath sounds I'm actually going to go over you guys in your individual labs whenever, whether it be Thursday. this Saturday for up north for our May City class. Tuesday, I'll go through breath sounds in person with you guys. It's really hard to explain over a PowerPoint. Um, when we see that IE ratio, what it's referring to is internal or inspirations versus expiration. And they say that, normal is one inspiration versus two exhalations. So one big deep breath in, and you might exhale twice on the way out. Anything outside of that is considered abnormal. So maybe a patient, breathes in really quickly twice and breathes out once. That'd be IE of 2 to 1. I can't say that I really pay a whole lot of attention to that, and I can't say that you'll probably see that ever come up again besides this PowerPoint. Pitch does play a role, especially when we start talking about like stridor. Stridor indicating an upper airway obstruction. What you're hearing is almost like a whistling sound. That's usually caused by a small opening, as opposed to wheezing, which is a lower airway issue. That is usually lower airway constriction. Then we start to hear wheezing. Generally, you can hear wheezing without a stethoscope, but generally we're going to hear that in the lower lobes of our patients. And again, you can hear it if somebody's severe enough, maybe an asthmatic or whatever it might be. Stridor is truly a life-threatening sound, in my opinion. That's an airway that's closing or something that is stuck in the airway. And we have to try to figure out what it is. If you've ever watched Finding Nemo, when she tries to talk to the whales, that's kind of what it sounds like. Like just a very high-pitched, long noise. Abnormal breath sounds, wheezing, lower airway constriction. Bronchi is essentially phlegm that is built up within the lungs that is causing a rattling noise. Crackles indicates fluid. Stridor, an upper airway obstruction. And then we have what is called a pleural rub. So what a pleural rub is our lungs have different linings to them, different layers, kind of like an onion if you watch Shrek. We have gel or fluid in between those layers. So that when we breathe, that almost acts as a lubricant so that the layers aren't rubbing against each other, causing friction. What a pleural friction rub is maybe we're sick, whatever it might be, and that fluid is diminished. And those layers of the lungs are rubbing together. So what it'll actually sound like is literally sandpaper. Or it might, like, if you've ever driven down a gravel road really slow, that's a lot of times what it'll sound like as well. And again, we're going to go through these sounds during lab as well. So don't, I'm actually going to play sounds for you during lab so I can explain a little more in depth. Pulse ox, again, it has its place. Normal oxygen saturation is 94 to 99%. The reason we don't say 100 is because we can't measure anything past 100%. 94 to 99 is normal. It is not measuring the amount of oxygen within the blood. It is measuring the amount of hemoglobin that is saturated within the blood. That has nothing to do with oxygen. Somehow, some way, we just said in normal patients, this is how we're going to measure oxygen saturation. And in 99% of patients, it does work. But for the 1%, especially breather patients, get in the habit, if your service has end tidal, of slapping end tidal on people and looking to see what their numbers are. Again, I love pulse ox, but it has a place, and its place is generally beside end tidal monitoring in conjunction with end tidal monitoring. I Pulse ox alone doesn't really tell us a whole lot besides that the person has hemoglobin that's saturated. And even, it brings up during intubation attempt or suctioning. I, to be honest, I use end tidal. And when we go through the intubation section and learning how to intubate and everything, we're going to use end tidal. We're not going to use pulse ox. When I was doing my rotation in the OR, I specifically asked this question: is how long before I will start to see a change in my patient's pulse oximetry? And the anesthesiologist in there, you'll bag patients before they're going to get intubated. He stopped bagging the patient, and we sat there for maybe a minute and a half, 2 minutes, and the patient's pulse ox dropped like 1%. But if I look at the end tidal, it creeped up almost immediately. That was the big thing for me then was okay, so pulse oximetry can't really be relied on, especially in our breather patients. The reasons we can get bad pulse ox readings, light can affect it because that is really an infrared light inside that little pulse ox that goes on the finger. Um, Patient moving around, poor perfusion. So if the patient's really cold, really clammy, a lot of times, warming up their hands will help out somewhat. If you have a patient that's severely hypothermic or has frostbite on their hands, their pulse ox can be really skewed. Nail polish can throw it off. Um, Abnormal hemoglobin levels can also mess with the pulse ox oximetry reading. Some services carry CO oximeters. I don't know of any personally. I might have had somebody from the last class that mentioned they carry them. It's essentially a pulse ox, but you're just measuring um, the amount of hemoglobin that's saturated with carbon dioxide, and then you compare that to pulse ox, and that should give you a more accurate number. To me, let's just use pulse ox and end tidal. End tidal gives you realistic, simultaneous numbers as the patient is breathing, live numbers. All right, let's take a 5 minute break. Come back here at 7:36. Like I said, we're gonna go till we might go till like 8:15. Um, but yeah, come back here at 7:36 and we're gonna jump right back in. All right, we're gonna keep on trucking here. Peak expiratory flow. If you've ever had a physical done for work, uh, then you've probably done a PFT test. Um, you know, peak functioning test, I think is what it's called, um, where you have to exhale as long as you can and as hard as you can, so they can measure the amount of expiratory flow that you are blowing off. What they're doing is they're actually determining your tidal volume, they're determining um, how much air you can actually hold into your lungs and breathe out at the same time. Normal healthy adults is between 350 to 750 mLs of air, roughly. But again, that's nothing that we're going to be doing in the field, to be honest. ABGs, when you hear the ABG, it's referring to arterial blood gas analysis. And again, that's something we're going to be doing if we are looking at pH. If we're looking at certain other lab values, then yeah, we would be drawing an ABG. Um, so we have partial arterial pressure of oxygen. HCO3 is bicarbonate. And a big reason that bicarbonate is important is because if bicarbonate is skewed, that usually indicates it's a metabolic problem and not a respiratory. You know, a normal bicarbonate level, I believe, is between 22 and 26. So anything outside of that indicates that we probably have a metabolic problem. So big things that we should be looking at to determine respiratory versus metabolic is we're going to be looking at our pH. We're going to be looking at our exhaled carbon dioxide, and we're going to be looking at our bicarbonate levels, those three lab values alone. And I do have a worksheet that might help you guys out. And title should not be anything new to us. Detects exhaled carbon dioxide in the air that somebody's obviously breathing out. Different types. You'll see digital and waveform. That's most common for most cardiac monitors these days. You can see colorimetric devices. Your service probably still has them. I know mine does. I hate them, and I'll tell you why. Um, they look very similar to that. So they'll detect carbon dioxide and they'll turn gold. Gold is good was always what we were taught. Purple was bad. So if as you're not ventilating, that filter in the middle will turn purple. As you ventilate, if everything's good, it'll turn gold. The problem with this is that it relies off of acid. What happens if there's any sort of phlegm or vomit that touches that filter, do you think? What color do you think it'd change? It's going to turn gold. It's going to give me a false positive because it's trying to detect acid, which is what carbon dioxide is. Vomit is very acidic. So if for some reason I get any sort of vomit on that colorimetric device inside of it, I've now got a false positive that tells me that I've got good ventilation, a good airway status, which isn't truly the case. And you can even see here, replace with quantitative device as soon as possible. So basically it's saying replace with end tidal as soon as it becomes available. Colorimetric is good for, you do an intubation real quick. You want to slap that on there just to make sure you have good placement. That's fine. But you should ultimately be putting your patient on end tidal monitoring. Um, Old school capnometers. We now have them built into our nasal cannulas that'll show these exact same numbers. 35 to 45 is what we're shooting for. You can see a value of 38 here, and it will actually tell you a true respiratory rate based off of what it is seeing. We'll get into capnographs later on in the semester and how to read the charts and what we're looking for in regards to the graph itself. But the numbers are huge. I'll be honest, I use the numbers more than I do the actual graph, which is what we call waveform capnography. The good thing about waveform capnography is a graph. Obviously, capnometry is the numbers. Good thing about capnography is it can tell you if somebody is having like an asthma attack. It can tell you if there's an airway obstruction. It can tell you if you've gotten ROSC, post cardiac arrest. So there are some pretty important uses to it. But for your everyday patient, I'm more prone to look at the numbers than I would the waveform. And again, this is something we'll go through in person that I can actually show you on a cardiac monitor, and put it on either one of you guys or myself to show you the differences in breathing patterns. End tidal is the absolute way to go, especially when we go to intubations, when we talk about monitoring a patient's respiratory status. We should always be looking at putting someone in end tidal. Almost every service that I can think of carries some sort of end tidal monitoring, and they're going to look very similar to this. The one on the left is going to be your nasal cannula. The one on the right can hook directly to an endotracheal tube. Most of the cannulas now have the ability to deliver oxygen as well as take a reading. And you can leave that on somebody. If they're on CPAP, if they have an oxygen mask on or whatever, you can still use that underneath the mask. I'm actually going to jump over the waveform part because I'm going to come back to it probably next lecture after we've had a chance to mess around with it in the lab. It'll make a little bit more sense then. So just a quick reference guide. So it's really hard to see on here, but end tidal CO2 is high. Patient is hypoventilating, not breathing enough. End tidal is down. They are breathing too much. So down is below 35. Above is above 45. I'm literally drawing this with a mouse, so I'm not Picasso. I'm trying really hard not to mess this up. Increase end tidal is anything above 45. Decrease is anything below 35. It's really important during cardiac arrest as well if we are doing end tidal monitoring, because we can determine how well chest compressions are being performed. During a cardiac arrest, we shoot for an end tidal of 10. Anything less than 10 indicates that our compressions probably suck, or we have a really slim chance of getting this person back. Anything above 10, we actually have a pretty good chance of getting ROSC on this patient. And when we see ROSC, what we'll essentially see, let me go back to let me see if I can pull up one of those slides that might make a little bit more sense. No, nope, nothing. I'll show you this one. On figure A, you can kind of see how we go up and we peak up here. On the left-hand column here, 50 is the number. So we're like at 60 up here. So that's a patient that has really high end tidal readings. Anytime you see a shark fin, like you would see in C, that usually indicates bronchospasming, like asthma. Anytime you see a shark fin appearance, what we're looking for is a good, almost like this shape that you would see in D, and almost a nice square. D is an example of, if 0 is baseline, if I'm going to draw a somewhat straightest line on baseline, that's 0. When we breathe, we should exhale out all of our air, right? This is somebody that is maybe breathing too fast, or that is a little anxious and not fully exhaling. They're taking a breath in really quick during the exhalation process. That's why this right here does not come back down to 0. Otherwise, the shape of it is pretty good. But what's important to note is, like, during a cardiac arrest, what we'll see on there, we could essentially see this. End tidal is 0. That's bad, real bad. But we could be watching this, and what we'll see is if we got ROSC back, we'll literally see this, and it probably come down on the other side like this. What we're seeing is a massive spike in end tidal because the person's metabolism just kicked in. And then it might start to level off somewhere like this and just keep on going. So that would be an end tidal roughly of 50, because your number on the left side will always correlate to the graph. So if we look at some of these, like figure C, that's probably an end title of 25 roughly. If I was to come straight, God, this line's horrible. If I was to come straight across 25, 30 roughly. But again, that shark fin appearance usually indicates something such as asthma. And why that's important is because we know how to treat that. We can give the patient a nebulizer treatment. Figure D, I'd probably try to talk that patient into calming down. To be honest, that to me that seems like an anxiety attack. Figure B, I'll be honest with you guys, I have no idea what's going on there. That might be CPR, if I'm not mistaken. That's probably an end title of around 12. And you can see those look pretty much like ventilations that are being timed, in my opinion. So an end title of 12, we have a pretty good chance of getting ROSC on that patient. Anything less than 10, again, not a good chance, or our CPR sucks. But we're going to spend a lot of time on that. So please, again, if you feel lost, that's normal. Protecting the airway, this is a pretty good diagram. As air comes in, it travels from our upper airway down into our trachea, down to where our lungs are going to branch off, which is called our carina, into our left and right lung. Now, if anything in that process is messed up, we no longer have a patent airway. In severe trauma situations, yeah, we can look at, the cricothyroid membrane, such as a needle cric. I'll be honest, I've only done one in my career, and it was under doctor's supervision. It's not something we do very often. But it is an option if things, are going south with our patient. That option is there. Uh, if patient unresponsive, has a pulse, not breathing, obviously simple maneuvers to open the airway. Unless there's trauma, we're most likely always going to refer back to our basics, right? Head tilt, chin lift. Literally grab the bottom of their chin, tilt their head back. What that does is it creates a neutral inline position for their trachea. It makes it easier for air to flow in and out. Now, if there's signs or suspicion of a possible spinal injury, obviously we don't want to be moving their neck around at that point. In that aspect, we'd go more towards like a jaw lift or jaw thrust, where we're not moving their neck, but we are displacing their jaw to allow for a patent airway. Um, Good part about it, doesn't take any specialized equipment. There's nothing too crazy that is needed for a jaw thrust maneuver, or not jaw thrust, head tilt chin lift. Maybe an OPA, NPA, some basic adjuncts. But besides that, nothing. Jaw thrust. If you've never done a jaw thrust, they're a little more difficult than you would think, to be honest. Where you're essentially grabbing right where your jaw would meet your oh, what's the term I want to use here? Where your jaw is going to hinge, and you're essentially just kind of pushing, like pulling and pushing forward a little bit, not forcing it, but it's going to cause the airway to open up. In trauma situations, those are the instances that I might look at intubating pretty quickly, especially if I think that I'm going to lose the airway or there's potential that the airway is going to be compromised pretty quickly. And also severe burns. Burns can cause an airway to swell up rather fast. So those I'm pretty quick to intubate as well. Tongue jaw lift maneuver. I can't say that I've ever done this. The only problem with this is essentially you're grabbing their bottom jaw and pulling it forward. The issue with that is your finger ends up in their mouth. And by God's chance, this person wakes up and decides to clamp down, you've probably lost a finger. I'm not in favor of sticking my fingers. There's only two types: a family member or a baby. There's only people that I will use my fingers to clear an obstruction or anything like that. Otherwise, I'll find a different way to open their mouth. I'm just not a big fan of putting my hand in somebody else's mouth. Suctioning, pretty important. It's one of the things that we take for granted a lot is having the ability to clear somebody's airway. Some can be hand operated, like you're going to see there on the left side. To be honest, I haven't ever used a hand operated one that worked worth crap. Your truck mounted units, like you're going to see here in the middle, which are, in my opinion, some of the best ones we use. And then you're going to have your portable suction, which you'll carry around. And you probably check in on your ambulance every single day if you're a good employee. Um, you should be checking it every day because the time you need that and it's not charged or it wasn't plugged in or a battery's dead or something like that, you're kind of up a certain creek without a paddle. I don't feel like we need to spend a whole lot of time on suctioning. If you need to clean a catheter, sterile water or even honestly saline, just suck that up into the catheter. If you need to clear any sort of clog or anything like that, that is a great way to do it. There's different types of catheters as well. You have your hard suction catheter or Yankauer, like we're familiar with on the left-hand side here, or you have your um, soft suction, which is going to look very similar to the one on the right, although that isn't a soft suction, but is essentially a straw that you can lower down through an ET tube if you needed to suction out blood, to suction out phlegm, vomit, whatever it might be. So that way it's a little bit smaller, it's a little bit easier to maneuver and easier to get around inside the patient's airway. Just remember when we're suctioning, not to insert the catheter too far because you can hit somebody's gag reflex. And the problem with that is that when somebody gags, it causes their heart to slow down. It causes a vagal response. And if I have a patient that's already somewhat critical, I'm not really wanting to slow their heart down. And also, how much time I'm spending suctioning them. Kids and children are very, very dependent on their respiratory system. So if we take too much time suctioning them, that's suction essentially oxygen away because while we're doing that, we're pulling air out as well. That's why we spend a little bit less time suctioning kids as opposed to adults. And I would probably disagree with this. I would say it's 10 seconds, in my opinion, for adults, 10 seconds or less. But again, just try not to stimulate that gag reflex because we will see that vagal response. I shouldn't have to go through suctioning with you guys on how to do it. I honestly don't. I've never measured a Yankauer tip from the corner of the jaw to the mouth. I essentially just do it to get the whatever the mucus is, whatever the substance is out of their mouth. Um, but I've never truly measured it, to be honest. But if you need to measure it, you measure from the corner of the mouth to the earlobe, and apparently that'll give you the correct size. I didn't know Yankauers came in different sizes, so we're gonna move on. Airway adjuncts. We're in the downhill slide here, guys. We got like 19 slides left. Hang with me. OPAs and NPAs are the ones that we're going to be most common with. OPAs are awesome. I love OPAs. They're easy to put in. They provide a heck of a little patent airway. Bad thing about them is they can't be used in responsive patients. They are primarily unresponsive, non-trauma patients, or you can use them in trauma patients. I don't know what I was thinking. That don't have a gag reflex. Gag reflex, OPA is not good because we're gonna get that vagal response. Patient could potentially throw up, and then we've got another situation on our hand, right? Um, Insertion, there's a couple different methods. You can literally use a bite stick and insert it straight down. I insert it sideways and kind of rotate it 180 degrees just to get it into position. This is where measuring might may not be a bad thing. I can't necessarily say I follow the textbook way measuring, from the angle of the jaw to the mouth or whatever it is. I really base it off the patient's size and whether I think that they're going to need a larger OPA versus a smaller one. But remember, this is for unresponsive patients without a gag reflex. And we'll spend time in lab putting NPAs in. I'm sure you guys should have actually already done that. NPAs, great. To me, they're super easy. Statistically, we have one nostril that is bigger than the other. So if you go to insert an NPA and it will not insert into one side, try the other nostril. Our bevel is always going to face the septum. Meant for patients that are, this could be awake patients, conscious patients that can accept an NPA. It's just non-trauma patients, just for the simple fact that we don't want to oxygenate the brain in a certain way because the NPA is touching it. if you know what I'm saying, like such as a facial fracture. So non-trauma patients, but otherwise it's great for conscious patients that you need to get an airway on, or if you need to assist them, or for a quick placement. The problem is you might need some lube, and tearing that open is always a real treat. Doesn't protect from any sort of aspiration. If you're looking for total protection for aspiration, you're going to probably look at intubating that patient, and even that's not a guarantee, because you can still get some that'll trickle down, and then you'll end up having to suction it. But NPAs and OPAs, you guys should know that, are probably going to be our most common forms of airway adjuncts that we're going to come across of. Now, measuring is from the nostril to the tip of the earlobe. Again, bevel faces the septum. So bevel always faces in. Bevel should never face out. We want it to follow the septum of the nose as we insert it. Common causes of airway obstruction in adults, foreign bodies. This could be somebody choking on food, their tongue. Again, that is the most common thing that you will see is tongue causing airway obstruction. That's why OPAs are great. Upper airway swelling, upper airway spasming, trauma. This could be trauma to the trachea, it could be trauma elsewhere causing a airway obstruction. Aspiration, so vomiting. We always get concerned about that, especially in patients that may have drank too much, and have potentially vomited. We always get concerned about airway management in those patients. Severe allergic reaction or infection as well. Tongue, again, simple to correct. OPAs, not a big deal at all. A total occlusion of the airway, total blockage of the airway is a huge deal. That is a life-threatening. You need to figure it out pretty quickly. And that might be through direct visualization where we are using a laryngoscope with some forceps to pull whatever it is out. I was always taught, and this is not textbook, so please I don't want to get anybody in trouble. But I had an anesthesiologist teach me one time because I was asking about an obstruction. And I said, what do I do if I can't get it out? And he goes, push it down further. He goes, because it'll go down into one of the lungs, but you'll still be able to ventilate the other lung. I'm probably not going to try that on a real person, just for the fact that I really don't want to get sued. Laryngeal spasms can occur when our upper airway feels that almost like tickling, right? It's a reflex. That's why in that video that I showed you, he was using lidocaine to numb up his upper airway. It's just so he didn't have those spasms. Laryngeal edema, really common in anaphylactic reactions, upper airway swelling, really common in burns. That's why we're quick to intubate people that have had severe facial burns, singed nose hairs, singed facial hairs, is because the potential for airway compromise is there, to be honest. Honestly, if it's to the point that you think the edema is going to occlude the airway, I can't say that. My first reaction is probably going to be to RSI side that patient and take the airway, because then I know I'm safe. I'm not going to waste time. Well, maybe I should try this drug first, or this first, or that first. I'm probably going to, you know what? I'll fix that stuff secondary. Their airway is pretty important to me. I'm probably going to focus on that first. Crush injuries, trauma to the larynx, trachea. Think somebody hitting essentially their windpipe, and the degree of injuries that we could see from that. Aspiration, yeah, when we start to vomit, we see that vomit carry over into the airway, which can lead to aspiration pneumonia, which can actually lead to death because the patient gets a severe infection in their lower airway. All right, we're at slide 98, and the next slide actually jumps into something totally different. So I think this is probably a decent stopping point for the night, if I'm not mistaken. It is 8 o'clock, so we hit 2 hours exactly. Let me see here. Tonight was a lot of new information for you guys, and especially when we start to talk about pH and the bicarbonate and N tidal. That's all new information for you guys. I don't expect you to pick up on it in one night. tonight is me just kind of breaking the ice because I haven't even begin to dive into some of that stuff. And it's a lot easier for me to explain some of this stuff in person as opposed to over a um, PowerPoint lecture via Zoom or Teams. And this, to be honest, is probably the hardest chapter to cover, which is good to get it out of the way. But there is a worksheet on D2L or not D2L on Canvas that I labeled acid base balance worksheet. You do not have to do that this week. I'd like to get through a lot more Airway before we cover that. And I'd like to go through it in person with you before we cover that as well. Um, and I'd like to be able to talk about it a little bit more instead of just assigning you guys a worksheet. I don't think that's fair to you guys. There aren't any other assignments that I'm giving you this week. You'll see that I uploaded a medication drug card sheet onto Canvas as well. That's not, I'm putting it up there for reference because I will be handing it out individually to you guys during your lab sessions on what I expect, and I'll kind of talk about that a little bit at that time in reference to your drug cards. Aside from all that brand new information that you guys just got, what no, I guarantee nobody's gonna say anything, but what can I answer for you? What can I help you out with? What would you benefit from? What questions do you have? And again, paramedic school. Oh, go ahead.
Um, Mine is just a question I had in the chat about the labs in Mason. Where is it at and whatnot?
It's at the Mason City Fire Department. Every other Saturday starting this Saturday.
And that's 8 to 4, right?
Yes, but I highly doubt we'll be there till 4 most days.
Okay, thank you.
Yep.
I have a question. Whenever you have a patient with any sort of trouble breathing or anything, do you always get end tidal?
I do personally, yes. Just because I like to, for one, it's good experience for me to put end tidal on my patients and for me to monitor them. And it kind of impresses the hospital a little bit as well when you come in and you start talking about their end tidal numbers. And it's another way for you, it's another vital sign, in my opinion. So any sort of respiratory patient I put on end tidal. I also put patients having a panic attack on end tidal if I think they're having a panic attack or an anxiety attack, because what I'll see is that they're breathing so fast that they're blowing off too much carbon dioxide. So I'll see that lower number below 35. And then my goal then is to just kind of try to calm them down, and then I'll kind of monitor that number as they start to calm down a little bit until they start to get in the normal range. And I'll start to, how are you feeling? Are your arms and legs still tingling, that sort of thing. But I'll put end tidal on everybody. I think it's an absolute great asset and a great vital sign. And like I said, I'll go through that in lab with you guys. It is awesome. I absolutely love it.
Thanks.
And again, this is just an icebreaker into airway management. We're going to spend a lot of time with this. You're going to have to do rotations in the OR. You're going to have to spend a lot of time with the airway. So if you feel like you're lost tonight on some stuff, that's fine. You're right where you need to be. Don't get too freaked out. I promise you, we get more in depth with it. We explain it a whole lot more. We spend a lot of time on it in the lab. It's paramedic school. It's going to be rough. What other questions can I answer for you guys?
If we missed part of the, go ahead.
Yeah, go ahead.
If we missed part of the lecture, when do you think it will be posted to the YouTube page?
The YouTube page, probably not the next day, but you can watch it on Teams immediately right after it ends.
Thank you.
Yep. And use that to your advantage. Look back through the lecture if there's something you think you didn't understand, or you remember a question that somebody asked and you thought it was relevant to what you're trying to figure out. Absolutely use it to your advantage. Although I'm not giving you a homework assignment for the next week, what I'd like you guys to do is spend some time looking up end tidal. Whether it's videos, whether you're reading something, spend some time looking up end tidal capnometry and capnography, and looking at different graphs and trying to understand a little bit what you're truly looking at. And it could be an article in EMS 1, Fire Rescue 1. I don't care. Look at something besides your textbook. Find a video, again, like I said, on YouTube. Find an article to read. Find something that kind of piques your interest that you can kind of focus on. Because that's truly what's going to help you out. Not just me going through a PowerPoint, but you kind of doing some studying of that on your own. So that would be my assignment to you if I was going to give you one. Look at end title and study end title for the next week. In regards, Joe, in regards to your message, will this be relayed to our instructors if we are not coming to Mason City? So the main instructors that be coming to Mason City is me and Cheryl. But yeah, it'll be relayed to everybody. And it's not one thing we're gonna be doing. We're not gonna spend just one lab covering it. It's stuff we're gonna continually do throughout our lab sessions. I'm excited for lab. I know we've still got to check off some EMT competencies, but I'm really excited to get into airway management with lab and go over end title and go over innovations, because this is truly some of the fun stuff, and kind of, watching you guys grow and develop and your knowledge kind of expand a little bit. And again, you got a lot of information thrown at you tonight. Your head should feel like scrambled eggs. I promise you it's worse. But you make the most of it. You get out of it what you put into it. So for the next week, I want you guys to read up on end title, find an article outside your textbook. And so that way next week when we come back to this lecture, you might have a little bit better understanding. If you guys don't have any other questions, you're free to leave. If you do have any other questions, I'll hang around for a little bit. But otherwise, you guys have a great night.